And today's topic is going to be the art of the doctor-patient relationship. And we're delighted to have several panelists, some physicians at Cedars Sinai Medical Center, as well as some survivors, cancer experts, and advocates for cancer. And I'd like everybody to introduce themselves before we dive into the program. The program is primarily going to be interactive. I will pose some questions to our panelists and ask them to comment. I will be watching the chat room on a regular basis to see whether there are questions coming from any of you, and please feel free to send me chats, and if you want them posed to a specific person, I'm happy to direct them. Otherwise, I can take them and direct them where I think is appropriate. So thank you for that. So let's start by just welcoming Dr. Basho, Dr. Shao, Dr. Stipek, and Shari Saraceno, who are joining me today. And we'll also be joined by Dr. Chung momentarily once she gets out of the operating room. And we're also joined by Dr. Asher. So why don't we start with some introductions? Why don't we start with our guests? So Dr. Stipek, if you could just give us a little sense of who you are, why you're here, and your thoughts on what we're trying to accomplish with this doctor-patient relationship in this series. Thank you for joining us. You're on mute.
Okay. Well, thank you. Nice to meet you. So I am a person who's a breast imaging radiologist. And for those of you who don't know what that is the person who reads your mammogram, who tells you there's something wrong with your mammogram, who then proceeds to biopsy you, and then tells you the results of your biopsy. So I have been doing that since 1997, and in 2016, I was on the other side of the table, and I had breast cancer myself. It actually recurred in 2018, so I'm just 1 year out of chemo, radiation, and the whole bit. And so in that journey, I discovered Dr. Asher and the GRACE program, and I'm a big fan of Dr. Asher. And so he requests, and I say yes.
Thank you so much. Shari, tell us a little bit about yourself and your journey.
I knew of Cedars Sinai before this, but when I was 28 in 1989, I was diagnosed and admitted into Cedars Sinai on Valentine's Day. And I had a rare and undetermined cancer at that time. And later in that year, I was honored as one of Cedars Sinai's Cancer Survivors of the Year. And 31 years later, I am now on my third journey with cancer, and I will be celebrating on Veterans Day. There's something about holidays in me. I like to get my diagnosis on holidays, so I have a whole new meaning for celebrations. I will be celebrating 5 years with metastatic breast cancer to the bones. I think Cedars is by far the best hospital in the world and has the most wonderful doctors. To be on a panel like this and to see that doctors actually want to know what makes a good relationship. As a rep that's been in sales for my whole career, now just retired with physicians and hospitals, this is the first hospital I've ever seen do this. So I commend you for wanting to know more when you really don't have to ask these questions. So thank you for having this tonight.
Well, thank you for taking the time and joining us today. So Dr. Basho, tell us a little bit about your role yourself and what you're doing at Cedars.
So I am a breast medical oncologist here at Cedars. I focus my clinical practice on the care of breast cancer patients. And alongside clinical care, I also spend some time doing breast cancer research. I design and run clinical trials. Like everyone else here, I'm a huge fan of Dr. Asher. I don't know how my clinic would function without him alongside. And I think this conversation that he has planned for us today is such an important one. I think it's something that we as physicians debate and discuss a lot. So I'm very interested to hear all sides of this conversation. So thank you for organizing this.
And Dr. Shao.
Hi, I'm Stephen Shao, and I'm a radiation oncologist. And I I also see primarily breast cancer patients in the clinic and do a little bit of immunology research on the side. I think I also echo Dr. Basho in that I really am very grateful for Dr. Asher and his program. I think, as we thankfully have seen a lot of patients live longer and longer, lots of things have come up, and so I think we're feel very lucky to have Dr. Asher alongside when we're taking care of patients. So thank you for having me.
Thanks, Steve. So Arash, why don't you give us a brief overview of your program and what your thoughts are about bringing this distinguished group of people together?
I get to sneak away in the background, but I guess not. Thank you. So thank you all for joining. As Dr. Figlin mentioned, this is the first of a series that we hope to do probably about every quarter or so to connect with you all on important topics. In my mind, one of the reasons Dr. Basho and I thought about this as the launching topic is, at least with the programs that we've done in our Wellness, Resilience, and Survivorship program, I've seen one of two things. One, how healing and how important the patient-doctor relationship can be when it goes well. And occasionally, when it doesn't go well, how it might, at least to some degree, contribute to some of the distress or trauma that may persist after the treatment ends. And so we thought it would be great to kind of have an unscripted, kind of honest conversation about what makes it work and what does it not make it, why does it not work well sometimes. And again, I thank you all for joining.
So let's start by posing a question. So to both the physicians as well as to the advocates, the challenging thing about cancer in 2020, you heard from Shari that her journey's been over 3 decades, which is amazing, is that we've all been touched by cancer. Our parents, our siblings, our family members, our children, our friends. And we all kind of enter this space with a perspective that is sometimes different than each other. And I guess let's start with our advocates and just look at through the lens of starting with you, Gretchen. What constitutes the right kind of physician from your mind? What are the attributes and activities that you see in the people that have cared for you or the people that you have cared for that drive what you consider to be an experience that is a positive contribution to your journey?
So as a patient, I think that number one for me is competence. I'm not going to care if my surgeon is nice or not. I just want them to know how to take out that cancer. And so, God doesn't give everything to everybody. And there are many surgeons who are magnificent and just don't have great bedside manner. But I'm okay with that as long as you do a good job. So that's number one. But I feel that different doctors have to have different abilities, right? So to have an oncologist that's dry is a little bit worse than having a surgeon that's dry, right? So the oncologist, again, competence is first, but then just being kind is a little bit more important there. But I would say one of the most important things is to listen. And I think that a lot of doctors don't necessarily listen because at a certain time, we decide, oh, this person's just sad or whatever, or not, or making this up. I think we have to be, maybe we get fatigue of being told a lot of things a lot of the time. And so I think it's very important to listen. So for example, I'll give you an example of Dr. Asher is somebody who listens so well that when I first saw him, I thought, oh my God, it's like he's had breast cancer, because everything I said to him, he was predicting my next, complaint, so to speak. And I think I've had people neglect things in my case, unfortunately, because they didn't listen. So I think competence and listening are the most important things. But I think you can't listen if you're not, if you're not truly caring. So I think that's a very important thing. So I think sometimes a doctor will have an ego that serves them well. So to speak, let's say that you're my doctor and you have a big ego, and your ego is going to tell you that you want to do really well by me because it's your reputation, right? You're going to feel it's very important to you to do the correct thing. So I think that's part of it. You have to have somebody who really cares about being to be the best doctor that they can in every circumstance.
Sherry, why don't you embellish that? What are your thoughts about that?
So I think every patient might have a different idea of what they think a good patient role is. I don't want an ego. I don't care if you're brilliant, but I am putting my life in your hands. And that is the biggest trust I have to give anyone. I don't have to give that to any other relationship in my life, but I'm giving you my life. So the ego needs to stay at the door. I know you're brilliant because that's why I came to you. And so I want you to trust. I need to have a trust with you that I have with no one else. That to me, I have an oncologist of 31 years. She's brilliant. She, to me, is the smartest oncologist in the world. That is the trust I have with her. We communicate perfectly. There is no question I ask. And believe me, I have asked a lot of questions in 31 years that is not pertinent to my well-being. And I will give you an example. At 28, it was an undetermined cancer. We did not know what it was. We did not know how I got it. I was 28, working out, eating well, doing everything right, but I did not know why I got my cancer. I'm in a young family. No one else has had cancer except for like a 99-year-old grandmother, which makes sense to me. So when I had to struggle with why did I get cancer, I asked her, and you're gonna laugh, but I'm gonna tell you my question so you understand why answering each question to me is important. I said, do you think that because red licorice has red dye number 33 in it, and I eat red licorice and then I go to the tanning salon, I got this cancer? And she did not look at me like I was a fool. Now, I know that did not cause my cancer, but I needed my questions answered. And her answer was this: no, I don't think it's that. I understand your need to have an answer, but we just don't have one for this. But if that helps you to feel that and that calms you down, then you can think that, but that's not what caused your cancer. So she never discredits me. And that to me is not having an ego. She didn't roll her eyes. She didn't flap her head back. She's clinically brilliant. I wouldn't be with her for 31 years and 3 different cancer diagnoses if I didn't think she was. I could have left at any time in that point. There was lots of years of wellness there as well. She also has a very good, wonderful side to her that I trust. She has a nice smile. Those things are important to me. It might not be important to, I can't read your last name, but I can see Gretchen, so apologize for not calling you by doctor. That might not be important to Gretchen, and that is what she needs in a doctor. And I think that's the hard part for physicians is, what do I need as a patient? Because you are you, but I might need something different than she does.
So now let's look at this through the lens of the physician, which is a bit of a different side of a coin. And I will tell you that I teach third-year medical students at UCLA and have done that for years. And teaching people how to be caring, empathic physicians is not easy. There's a lot of technical information that they must obtain. So Riva, when you walk, you have a busy clinic. You're seeing many patients over the course of a day. You walk into a patient's room, and the question is how do you frame what you think are the attributes of a good physician when you walk into that new relationship? How are you thinking about that?
Yeah, I think the 2 answers so far highlighted one of the biggest challenges as a physician is that each patient is so unique, and as you enter the room and start to get to know a person, you have to be able to adapt to what their needs are. And for the most part, you can tell fairly quickly what is truly important to a patient, and being able to tailor that conversation in that direction is really important. As a medical oncologist, one of the biggest challenges I face day to day is that medical oncology can be done correctly in many different ways. So for each patient with the same scenario, you can have several different modifications to the treatment plan that are all correct. And having that discussion about approaching that treatment plan in a way that the patient identifies with is really important. It's important to be flexible to the needs of the patient, but also important to be decisive enough to guide that conversation so that it's productive. And having a fine balance between that flexibility and that decisiveness is probably one of the biggest challenges that I face with each patient interaction, but one of the most important things.
So let's talk to Steve. I mean, so Steve, the patient already has a diagnosis of cancer. They've seen the surgeon and the medical oncologist, and they're obviously coming for a very specialized treatment or thinking about the relationship of the radiation oncologist to their care. What unique aspects of that physician-patient relationship do you incorporate when thinking about how to sit down and talk to a patient that you've not seen before?
Right. I mean, I think that one of the most important things, other than kind of what's already been said, is, I do think that it's a big deal to listen to what I think are the patient's most important concerns. And I think one of the challenges with radiation in particular is that it's a very unfamiliar thing to people. And I think that most of the patients I encounter, you have all these, I think, quite scary notions about radiation. I think some things, surgery seems, I think to patients more accessible than radiation, which is sort of this invisible, terrifying force, and most of the time is depicted terribly in movies. So I think some of it is really trying to hear kind of what's gone on, actually. And so because I know that a lot of patients have been through a lot already by the time they've seen the radiation oncologist, and being sure that, I reassure them that they've kind of come a long way already, and that this isn't going to be the sort of the worst part of it. In fact, we're going to try and make it be, as easy and smooth as possible. So I spend a lot of time listening to kind of what actually, how the surgical experience has gone and how the chemotherapy experience has gone, and try and contrast that with what is going to happen to make it feel like that the radiation is a little bit less scary. So I think that, part of it is just we spend a lot of time listening in our clinic.
So Arash, I'm going to put you on the spot. So far, we've talked about what makes a good physician and what makes a good patient. So you've seen a lot of patients, and patients come in a variety of different forms and structure. And we'll obviously come back to Gretchen and Shari in a moment and ask them what they think a good patient, what makes a good patient. But what do you think the characteristics, because the reality is that the doctor-patient relationship is exactly that. It is a relationship between two people. It is not one-sided. It is not the doctor drives it and the patient listens, or the patient drives it and the doctor listens. So as with all relationships, there has to be contributions from both sides to make it a good relationship, even in the setting of cancer. So looking at it through the lens of your experience, what are the attributes that really make a good patient in this scenario?
So I'm biased, obviously, but I do have thoughts about this, and partly because, and no offense to our surgeons and medical oncologists, but if you think about it, they're doing something for you, right? They're giving you the drug, and they're giving you the radiation, they're operating. By the time, typically, that I see someone, when we're thinking about, how to get your fitness back or how to change some habits or patterns. It's all on us as the patient to change that. So, and this is not always feasible, but in my mind, the ideal person is somebody that has some sense of investment, that I'm not going to just wait for some magic pill, because the reality is there is no magic pill to address most of what ails most of us. When we think about, the distress, the existential piece of what happens, a lot of this is going to require us to take some ownership. And and I always honestly try to convey that idea with the people that I work with, to try to make this a partnership rather than expecting the physician, whether it's me or anyone else, to hand you something that's going to cure everything, which is probably not realistic.
So Shari, to you, what do you think about your 30+ year journey made you the ideal patient?
Well, I do think I'm her favorite patient, but that just might be me. I think what makes an ideal patient is that Dr. Asher said, I'm a very active patient. So when I go for my appointment, I have my list of questions that I've kept running for the month I didn't see her. And lots of those questions get taken off during that month. And I'm down to the 3 or 5 questions I have for her. So I'm prepared when I get that crucial time that's allotted for me. I'm prepared. And I also take notes so that I know the answers. I don't forget them. If it's a crucial appointment with COVID, no one can come with me right now, I would put someone on a speakerphone because I may not hear those answers because they might be too much for me. So I might have my niece on cell phone to take the notes for me. Because as a patient, we shut down sometimes. We can only hear maybe the first few words of something, and we need someone to take those answers. The other thing is when I go into that office, I am as joyful as I can be because not everyone can be joyful every day. So that they have a tough time in that office. So when I go in there, I'm in the best mood I can be in because I want the best results I can have. So if I can just check in happy, get my lab work done happy, get to her happy, it's a better day for me and it's a better day for everyone I come in contact with. Because there may be a day I'm not in a great place and I need someone to pick me up. So that's what I feel is my responsibility, to go in with a clear mind, upbeat, and not everyone can do that. I'm not saying everyone has to do that, but they have people that are sick all day long in that office. So if I can bring a little joy, be prepared, be on time, and know what I'm there for, that to me is a good patient.
So Riva, how do you think, again, going back to the scenario where you have a day of seeing patients and each patient is obviously coming in with their own personality and their own set of situations and they're in a different place in their journey. How do you navigate the personality of the patient that optimizes your ability to deliver care?
Yeah, I think as a patient, one of the most important things to advocate for your care is to openly communicate. And that means being comfortable enough, even if you've done things that don't align with perhaps what the oncologist prescribed or discussed, that's okay. Because if we don't understand why or how, we can't help guide or make the right decisions or change things. And ultimately that relationship isn't going to produce the results that both of us want it to. So I think an open line of communication between both of us, and that's a two-way street, being able to be flexible and as an oncologist, not always pound what might be my belief, but understanding sort of the circumstances and what might be happening with a patient. And adjusting is really important, but keeping that line of communication always open. And sometimes that is real time at the visit, and sometimes it's, not at the visit, but it's the need to call the oncologist and say, hey, I need an extra visit because this is going on. But keeping that sort of line of communication open so that we can guide care is so important.
So I want to make sure that during the course of this hour, we also tend to some of the questions that are coming through, and one fits very nicely here. So we got a question via email. They asked what training do doctors have on communication and facilitation of difficult communications with cancer patients? In quotes, I've heard time and time again, the doctors do not get training in medical school on a variety of things that actually are within the scope of their job. So, I mean, I think, Gretchen, you're in a really unique position. You are a physician. You've been trained as a physician. You also are obviously traveling through a cancer journey, so you can see things from both sides of the conversation. How would you answer a person asking questions about whether physicians are trained well enough to have these difficult kind of conversations? And put yourself off of mute, Gretchen. There you go.
Sorry. So it's my belief that nowadays people do get some good training in that. But I graduated from medical school in '91, so I don't think that I got adequate training. I think that, however, with time, this was a subject that mattered to me. You know, it's just who I am. I like for people to be happy and to and not only at work, but everywhere. I like that when people have experiences with me, they have good ones. And so I paid attention. And I, you know, it's interesting because I trained in New York and people were different there. And when I got here, I think people felt that I was cold, but I was just trying to be professional, right? But by what I was told. But what I've learned is that now I've learned because I've paid attention. And I know that when you walk in a room, no matter how bad things are, you come in with a smile. You know, and you ask somebody how they are, and you know, even, you know, I do a lot of biopsies, and that's kind of something that's really not fun for people. But I always tell them, you know what, please engage in a conversation with me while we do your biopsy so that, you know, it'll be as good as possible an experience. And most people do. And, you know, we end up talking about their dog or their job or whatever, and we have a great time. So I do not think that I was trained. I don't know about you, but I don't think I was trained, but I paid attention, and it, you know, in time it worked out. But I do believe kids are being trained in how to talk to people, for sure.
Yeah, I mean, I actually want to ask Stephen about this, but I will say this. I've often said this to my students as well as people that I teach. You know, for those of us in the cancer profession, my own view of the world is cancer chooses us as much as we choose cancer to practice. We are not the usual people that choose medicine to practice. We're not, you know, all due respect, plastic surgeons, dermatologists, internists. I mean, those of us that have chosen cancer have chosen it for a reason, whether it's the science or the relationships or the chronicity. And it doesn't matter whether you're a radiation oncologist, an internist, or a surgeon or a rehabilitation medicine person. There's really a reason why we've all chosen this as our career path. Steve, how do you think that educational process has been facilitated? You trained at great places around the country. Where do you think it kind of met your need and didn't meet your need?
Well, I definitely think that I trained. So I'm about 11 years out now, but I would say that we were kind of entering a phase in which we were trying to introduce ways to learn to communicate better. I think it was part of the it was becoming increasingly recognized. I think when I was a first and second year, that I think some of the physicians, when they finished training, were really struggling with communication skills. I think, you know, really trying to figure out how to say some of the complicated and difficult things that we have to say as physicians. And so, you know, I would say that I hope that it's actually evolved too, but over time. But I felt like we had a lot of, for instance, practice conversations. So in my medical school, we got a chance to practice saying some of the things. I think in the beginning we got to see examples of people that many people in the community respected as great physicians have a conversation, like a mock conversation with patients and also with students. And I think that was really helpful. And and I think that I will say that it's been a bit of an evolving process too. That I agree with Dr. Stepek, that I think you kind of have to always be open-minded. That communication is not something you learn once. That's what I sort of learned the most, is that it's something that's this ongoing process. And interestingly, in modern times, I find that I communicate with patients in kind of all sorts of new and different ways. So I have a patient who prefers no verbal communication. So we text and we email, and I think that patient really prefers that. She is younger, but I think that we kind of have to evolve with different times, and especially now with I think COVID, I think I've learned lots of new things about how we communicate with patients. So, but I did definitely come of an age where we trained by practicing, and I think you can really it's something that hopefully has evolved to get even better.
So let's shift gears a little bit, and Shari, this is going to be directed to you. We've had a number of questions, and this is from our attendees about second opinions, getting other opinions, whether they're getting the right care, should they seek out another opinion. And you've had an unusual, I mean, you've identified yourself as being with the same physician for decades. And obviously you have to find a comfort level between yourself and your team. And it's teams that deliver cancer care. It's usually not individuals that deliver cancer care. What do you think, looking at it through the lens of the patient, I mean, what do you think the patient's rights are with respect to seeking other opinions, having conversations with their treating physician about wanting other opinions? Where do you think that sits in the relationship between the patient and their caregiver?
I know for sure if I ever told my oncologist I wanted a second opinion, she is confident enough to say, go do that. And any physician that is confident would be. They would have a conversation. I think she would say, well, what are you doubting, or what do you have questions on? But if you're doubting your physician and you want a second opinion, there's only one way to find out if you believe your physician is the one, and that is to go have a second opinion. For me, I truly knew she was the one, and I was admitted that day, and I've never strayed. But before I got to her, I was at a doctor's office who did not look at me and told his resident what he was going to do to my neck for a biopsy. And I walked out of the appointment, and I never turned back. And that's how I ended up with her. So that was my second opinion. So I believe that you need to have so much confidence in that relationship that you have to trust that person. So if you want a second opinion, then you go get one. If you're comfortable there and you go, this person is going to save my life, then you stay. And any doctor should not be threatened by that. And I don't think most doctors are.
So let me turn to Riva, and let me just respond. There's been two questions in the chat room, and I just want to provide some clarity. We've instructed our faculty and our advocates not to be sharing personal information about who cares for them and who their doctors are, and it's not because we don't think that that's something that's okay. It's just not the purpose of these meetings. So a couple of people have reached out, Shari, and said, well, tell me who Shari's doctor is, because that's
not the point.
No.
Who I love doesn't mean that's who you would love.
I know, and I want to be respectful of all of us, because we want to attend to the questions in the chat room. But the purpose of this is really to share our feelings around these issues, rather than trying to say mine is the best way to travel. So Riva, let me ask you. So Shari comes into your office, and she had an opinion by her physician, and she's looking for a confirmatory or some second opinion to decide whether she's on the right path. And you may or may not have total agreement, or you may have a differing agreement on how that person's been managed. How do you navigate that conversation with a patient so that they can embrace the fact that differing opinions are part of cancer care as opposed to right and wrong?
Yeah. I think, going back to what I said earlier, there are many different ways to do things right in medical oncology. There is no, even if you saw the same case scenario in the same day with two different patients, you might make two different decisions based on the conversation you have and the needs of that time. And so even though you may receive differing opinions from two different oncologists, it does in no way means that one oncologist is wrong. And so that's usually the beginning of the conversation that I'll have with patients. And usually when patients are seeking second opinions, they've done some research on the topic. And so going into discussing why we might make these nuanced decisions one way or another usually helps the conversation and helps guide that discussion in terms of what might be important to each individual patient and why we may choose one path versus another. But this is an issue that comes up so frequently in oncology because we can do things in different ways.
So Arash, I know that you've been waiting patiently for me to call on you to provide some insight. So two things. One is not so much about the second opinions, but really about the patient-doctor relationship, if you could just make some observations.
Well, I was taught a couple interesting pearls when I was in medical school. So where I went to school, University of Rochester, they had done a study actually the year before I graduated, where they found that the average physician would wait 7 seconds. So when a patient comes in, and you kind of ask that person, well, what brings you in today? How are you today? And then let's say the patient starts to answer. On average, we would wait 7 seconds before we kind of interrupted. And what they kind of guided us on was to try to give it 90 to 120 seconds, which sounds like a really long time, especially for, as physicians. I know everyone's very busy, but I think that idea has served us well in terms of just giving a minute or two to kind of try to read the situation. So I think that one piece has been, at least personally, very helpful to me. I don't know if Sherry or Gretchen had other impressions in terms of allowing for that 1 or 2 minutes of time. And then I just like to share one personal story that I just occurred to me in terms of what leads us to, because all of us as physicians, we're all patients too. So we've all had some kind of personal experience that I think has impacted how we practice medicine, I imagine, to some degree. And what I remember, I was 7 years old. So I had just turned 7, and my appendix ruptured, which means this thing, the thing in my abdomen blew up, and I had an infection in my abdomen. And I was rushed to the emergency room, and it took a while. And finally, I was being shoveled off to the surgery room. And the surgeon, I still remember this very vividly, even though I was only 7. They were just focused on the abdomen, and I was taken away from my parents into the operating room. But what I'll never forget, even though there was very little time, there wasn't much time to chit chat and ask about how you're feeling and what's on your mind today, is I'll never forget how the anesthesiologist took 3 to 5 seconds and just kind of looked at you in a way that was deeply empathic, and just kind of said, everything's going to be okay. And just kind of I remember her putting her hand underneath the back of my neck. Those kind of experiences, I think, really can stay with us. And that's really when I began to appreciate, because of what I went through, how just just the tone of a voice and just a brief kind of connection for just 3 or 4 seconds can really, and I wasn't scared. I remember after that, really the entire time, with just the 5-second exchange that occurred there. So I think all I'm trying to say is really that it doesn't necessarily take much time. And the Rochester study suggested just 2 minutes can be all we need to try to create some kind of window to understand one another in a better way. But I'd be curious what Gretchen and Sherry think about that.
Well, I'm not going to let them because we have a whole list of things to talk about. But they'll have to go to your GRACE program to find out. So Gretchen and Steve, so I want to turn the table a little bit. One of the questions that's come up is how the internet is really changing how patients and doctors are being viewed through the lens of information. So Gretchen, what do you think? And again, you provide a unique perspective because you're both a physician and a patient. What is the good and the bad, or the good and the challenging associated with more information that people are getting? It used to be, well, I heard from my aunt that she experienced this, or I heard from my uncle, and now it's I heard from 1,000 people on the web that this is what I should be asking or doing. So Gretchen, how has information technology both helped and hurt the cancer patient going through the cancer journey? And then I'll turn to Steve and ask him through the lens of the care provider how that has helped or hurt. Gretchen, you're up first.
So I'm up as a patient or as a doctor?
Both.
Okay, so as a doctor, I'd say that it makes things many times a lot harder, because it's harder to battle a preconceived notion than it is to start from scratch, right? So what ends up happening is that people have all this information, and medical language is no different than, German or Russian for somebody who doesn't know it. So you're reading something in Russian, or medical speak, and you don't understand it, and then you get all confused, and so many times what I run into as a physician is that I walk in a room and a patient says, because I looked up this and this and this and this and this and this, and I feel like if they stopped and just let me explain what I can explain, and then kind of let's merge that with what you've understood, I think that would be more helpful.
And now do it from now take the other side, and that is from the patient side of your journey. How has information impacted your care?
I think it's been great, but I speak medical language, so I've been able to read and understand and inform myself and get a lot more journals that I would have been able to access, and have a lot more information about a lot of things.
And how about you, Steve? I mean, Steve, it's clear that you're in a very unique technological specialty, yet you have to deliver, caring care. So the question is how do you navigate through the information technology overload that we're all realizing every day for the patients to come in and see us in the office?
Yeah, well, I'll start by saying, as radiation oncologists, we love technology and computers, so that's one of our favorite things. But I will, I would agree with, Gretchen, that it's, sometimes I think it's a double-edged sword, right? I think there's more information available to patients, but winnowing through what, how it applies to a given patient individually, I think is a little bit challenging, because I always try and present to patients, I say, a lot of the things that you read, you have to just be, we all have to take a step back and just be sure we're that some things will happen and some things won't. And that, I always remind everybody that the people who are posting, or a lot of times, I think people read lots of patients like to read about it, other people's experiences, which I totally think is very helpful. But I do think that, that the people who are posting are obviously patients who've had mostly negative experiences or challenging or unusual experiences, and that you have to be a little bit careful about kind of interpreting that in the context of your own experience. So sometimes I try and help. I sometimes give patients suggestions if they really like to browse. I give them suggestions about websites that I like or that I think are useful. I like the American Cancer Society website or things like that. So I try and give them sources that I think are useful and interpretable. And then I also ask them, well, maybe sometimes I have them bring in the things that they think are the top couple concerns, right? Like you heard that maybe like, especially for radiation, like, this is going to happen. And then I explain to patients, well, that rarely happens. So I try and give, kind of a larger kind of scope back, like say, well, that can happen, but, it's extremely rare, for instance, and I try and give them some numbers to help patients kind of, I think, settle where they are. And I think that that's the part that you lose in the internet, is that it's hard to process all the scope of the information. With all the trees, it's hard to see the forest. So sometimes I think our job is to, because we've seen so many patients and read a lot as well, that we can give some forest to the trees. And so I think sometimes that's how I try and approach it.
So let's extend that to Sherry and to Riva. So one of the other things that's happening in our world is people are deciding which doctors to see because of the reviews that they're hearing about online. And Dr. Figlin's the best thing since ice cream, or Dr. Figlin's not the best thing since ice cream. Sherry, how much should we be using information technology to be choosing our doctors based upon what Steve just pointed out, by what people post? And then I'll ask Riva about what the impact of those reviews are on delivering holistic and best care. So Sherry, you're first.
I think we've learned a lot about the media and how it can be so swayed recently in these last couple of years. Everyone has an opinion. You don't know who's written that, so you don't know what their background was for writing it. Did they, have to wait because someone showed up late? Did you not greet them the way they wanted to be greeted, so they wrote a terrible review? Or is it your favorite patient like me and they write a million things about how lovely you are? I don't read reviews. I don't even read reviews on Amazon. I think everyone's got an opinion. You could be paid for it. So I make my own decision. The way I would pick you is by reading your CV and seeing what things about you do I like. Did you go to an accredited college? Do I like the research you've been included in? Do I like the nonprofits you do? Whatever I see about you, and then I'd find someone that knows you somehow. I'd call your office. I'd ask your staff what you're like. This is what I do. I interview you around you. That's how, because I have to go to other people besides an oncologist. I'm looking for an ophthalmologist right now. And I'm calling offices and going, what are you doing for COVID? How are you seeing your patients? I interview. I find the best. And when I had to go to a different hospital for my breast surgery in 2008, they said, we're going to assign you your surgeon. And I went, no, these are the two I want. And they're like, we don't do that this way. And I said, well, I'm your patient. These are the two I want. And the surgeon said, you're the first person to ever do that. And I'm like, what do you mean? That's just how they do it at this hospital. They assign someone, and I had to have tram surgery. So it was a unique surgery. I'm the patient. I need to know you're the best. I'm not going to take someone else's opinion, but I'm very stubborn and very set in my ways, if you haven't noticed. That's what you have to be as a patient. We have to follow up. We have to do what we need to. We have to be active in our wellness. So no one else's opinion is going to matter that I don't know.
And Riva, how has doctor reviews affected the practice of medicine through the eyes of a young practicing breast medical oncologist?
Sherry, I think you're absolutely right. You have no idea what the context of people writing reviews are. Some might be commenting on the waiting room. Some might be commenting on the parking.
Exactly.
And so I really don't change my practice based on the reviews. I'm in clinic every day because I'm passionate about what I do, because I want to take good care of patients, because I enjoy learning about breast cancer and treating breast cancer, and I do the best I can do, and the rest is it doesn't impact what I do on a day-to-day basis. And I don't think we can get too carried away by those reviews that really could be reflecting on many other things other than how I practice medicine.
So we have, I'm very conscious, and for anybody that knows me, I'm always conscious about time. And we have just a few minutes left, and I want to make sure we finish on time. So what I'd like to do is I'd like each of you, Gretchen, Sherry, Riva, Arash, and Steve, I'd like you to just, in one or two key points summarize for our attendees, what do you think the most important structure and function of the doctor-patient relationship is through the lens of what you care about? I mean, we've heard a lot about this, but I want you to succinctly try and bring that together in just a sentence or two that people could take home and say, oh yeah, that's the way I need to think about being with my doctor or with my patient. So Sherry, let's start with you.
I would say trust, knowing you're building a long-term relationship and you want that trust. And the one thing I didn't mention, but I would always ask every physician, never doubt that you might have a miracle standing in front of you. So don't ever give up that hope.
Gretchen? You're on mute, Gretchen.
Sorry. So I would say listen and learn to both sides. Listen and learn. And to patients, take a lot of notes and write down your questions before you walk in.
Steve?
I would say that don't be shy about asking questions. I always tell my patients I love questions because I think that helps us understand better and communicate better. So don't be afraid to ask questions. There's no question that's too small.
Yeah, and I think what Sherry mentioned earlier, just to elaborate on that, is I think as caregivers with patients with cancer, we recognize that communication is important, but communication involves two people. It involves the person giving the information and it involves the person receiving the information. And sometimes we as cancer providers have to recognize that patients sometimes are overloaded with information, and that having that information a little bit at a time and repetitively often offers the opportunity for hearing it. And I think your idea about, and it's not just during COVID, I mean, having a partner that comes with you, or a voice recorder that comes with you, or somebody that can also be a sounding board. I mean, I think that, you know, I actually started writing a book at one point in my life called It's All About Cancer is All About Family. And it's all about family because in reality, cancer affects everyone in the community, not just the individual. Rita, your thoughts?
I was just going to say, I became an oncologist because I like being a long-term doctor. I want to get to know you. I want to build a long-term relationship. So it's not just about treating the cancer. It's about truly getting to know each other's personalities and how we can work together to best fight your cancer long-term.
And Arash, you get the last word because you started this series and you're going to help us understand where you want to take it.
I would say if there's one thing, it would be important for your physician to know what matters the most to you, what you value the most. And it doesn't have to be a long diatribe, but just crystally understanding what are your most important values and goals. I think that would really help them to tailor something that really works for you.
And where do you hope this series is going to go, Arash?
Thank you. So, you know, we're hoping to do this once every 2 or 3 months. We're going to hopefully have a wide-ranging area of topics, from nutritional areas to cutting edge, treatment options that are available, or rehab options, or psychiatric issues. We're going to try to have the whole rainbow of topics. And please, I think you're going to have an opportunity to give some feedback on topics you'd like to hear about. And we're going to do our best to get the best panelists within the entire Cedars Sinai system to address those topics. So please share your thoughts.
So finally, Gretchen, Sherry, Rita, Raj, Stephen, thank you so much for sharing your time with us. I will say this, I think that what tonight illustrates mostly for me is that the patient-doctor relationship is defined by dialogue, and dialogue and communication are always two ways. They're the giver and the taker of that dialogue. And I think if anybody, if people leave this conversation recognizing that I think most of us really want that dialogue professionally and personally in our lives, and the office where we see cancer patients is no different than other parts of our life where we want that dialogue and that communication. So I hope that this is allowing our attendees and our wonderful faculty to acknowledge that our goals are very much aligned. And I wish you all a safe and good night. Take care.
Thank you.
Thank you, Sherry and Gretchen.
Thank you, Dr. Asher, so much. Appreciate it. It was fun.
Good evening.
Nice to meet you all.